Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up sessions. It's part of our adult opportunistic infection section, and we're going to look at how we assess a severely ill patient. So we'll start off with our case, which is Mr. PK, who is 38 years old, and he presents to the clinic with the following symptoms. He's had weight loss, quite a dramatic weight loss of over 8 kilograms over the last 3 months. He has loss of appetite, he's feeling weak, he's fatigued, and he has diarrhea. He was tested for HIV 3 years ago and was HIV positive, but he never came back for his CD4 result, and he's not had any treatment for it. Now, this kind of a presentation is unfortunately still much too common, especially in our district hospital CHC setting, where you see a patient coming in with HIV who's very ill and with very non-specific symptoms. So they might come with non-specific illness, either cough or diarrhea, low-grade fever that's been going on for some time, and some constitutional symptoms. So they're losing weight. And when you look at the patient, you can think to yourself, this patient is ill. I'm worried about this patient. But there's not a very clear picture of what is the cause of the illness. When you look a little bit further, you would normally find they've got very low CD4 counts. And these patients are at a high risk of death. So quite often while we're busy doing the investigations to try and find out what's going on, they might die in our hospital. Very important to keep in mind that it's usually multiple diagnoses. And I think the biggest reason why patients quite often demise is because we're chasing one diagnosis and we're treating one diagnosis, and meanwhile there's something else that is also happening. And of course, there's non-HIV related causes too. So the patient might be suffering for something that's got nothing to do with his HIV, but is making the picture even more complicated. So let's go back to our patients, Mr. PK, and what are we gonna check for at this point? Now, when you're assessing your patient with a very low CD4 count, it's very important to be very systematic. And I've put together a little hierarchy here of the major systems you need to think about. So if you've got a busy clinic, you can't do everything. These are the 5 essential areas you must go through. And the first thing we're going to look for is always our pulmonary system. That's by far the most common presentations of patients with HIV, whether it be tuberculosis or infection, and that's the area you want to prioritize first. If your pulmonary system is clear and you don't think there's TB, for example, you need to keep extrapulmonary TB in mind and see if there's any symptoms that might make you suspicious of TB in other areas of the body. High up on our list is also neurological conditions. Not necessarily that they're that common, but they're very dangerous. So quite often these are the things that's going to kill off our patients while we're busy trying to investigate. Cryptococcal meningitis iris is a good example of that. We also want to carefully examine the abdominal area, especially looking at the liver and looking for large lymph nodes. And then lastly, other systems which are actually very common, like your skin and mucosa membranes, but they might not be as dangerous. But you definitely want to have a good look at the whole skin of the patient, especially for hidden lesions such as Kaposi sarcoma. So what happened when we had a conversation with Mr. PK? So first we wanted to check his pulmonary system. We discovered that he's got no cough. We're asking about fevers and night sweats. We're already thinking a little bit further in terms of extrapulmonary TB, and he's definitely had fever for quite some time, and he has drenching night sweats. We want to know about TB contacts. He doesn't have any, and TB contacts in adults is not as useful as it is in children, as somebody might have been infected with TB quite some time ago. And might have been infected, for example, catching an overnight taxi or an overnight bus, or at work, or in scenarios where they might not even have known that they've been exposed to TB. And it's only now when the CD4 count is quite low that the TB is presenting. We want to know about previous TB history, and that'll get important if we're thinking in terms of treatment. And this patient does have previous TB, so that makes him certainly at a higher risk of TB waking up again. We also have to ask particularly about the diarrhea and the abdominal symptoms. Is it acute? Is it chronic? Is there blood? Is there mucus? Is there associated pain? To start getting a clue of what the cause might be. And our patient tells us that the diarrhea has been grumbling on and off for the past 3 months. The current episode has been for 4 days. There's no blood, there's no mucus, there's no vomiting, but he does have occasional stomach cramps. When we examine our patient, this is what we find. He's ill-looking and emaciated. He has a fever and quite a low blood pressure, 90/60. He's pale, no jaundice as such, fairly well hydrated. He's got a bit of oral thrush, diffuse shotty nodes. When you look at the respiratory rate is normal, chest sounds clear. Cardiovascular is a bit tachycardic, which is not surprising looking at that fever, but otherwise all right. Abdomen soft, diffusely tender, maybe a little bit of hepatomegaly, no splenomegaly, very non-specific findings. And skin is a little bit dry with excoriations, no unusual lesions. So this is a common picture in a patient with a low CD4 count. You can see that the patient is sick. You can see that they're immunocompromised, but there's nothing really that jumps out at you in terms of a diagnosis. Very important here is to become very clear about your differential at this point, and to stay away from the temptation to go for the single diagnosis. You want to think broadly, and you want to think of how different things can complicate each other. So, of course, very much at the top of our list for a patient like this is Mycobacterium tuberculosis. He doesn't have specific chest symptoms, so we are concerned about extrapulmonary TB, and we're particularly concerned about a disseminated picture of the TB. We're also worried about the diarrhea, which might be a completely different diagnosis. There might be some sort of chronic gastroenteritis, and our two top culprits here will be cryptosporidiosis and Isospora, especially as the diarrhea doesn't have much mucus, it tends to be more watery, and those are common pathogens with patients with low CD4 counts. Microsporidium is sometimes a bit of a red herring, but can also be contributing. But of course, somebody with a low CD4 count or somebody that's very ill, there's a whole list of other things we need to consider. You can also get the gut directly affected by the HIV. You might have a CMV colitis. His disseminated picture might not be due to tuberculosis at all. It might be a Mycobacterium. It's a non-tuberculosis Mycobacterium. He might have a disseminated fungal infection that's making him so unwell. So when you're starting to investigate, you need to keep this in mind, and we investigate for different aspects. So firstly, we want to know how immunosuppressed is our patient, because that's going to help for our differential diagnosis. The CD4 count is very useful, and your full blood count and diff is very good in terms of giving you an indication of how sick your patient is. We also want to see if any of the organs have been compromised. It can point to a diagnosis, but more often it also tells us about the level of illness. So our U&E will tell us how much strain the kidneys are under, and our liver function test can give us a clue if there are infiltration potentially of the liver. But more importantly, we need to find the cause, and we are looking for TB. We don't have a nice pulmonary TB where we can easily find sputums, and so we need to try and find some sort of sample. The use of CRP is always questionable. It's not very specific or sensitive. It's always very reassuring when you have a very nice high CRP as a clue towards a possible TB diagnosis. But remember, a normal CRP does not exclude TB. And we want to start getting samples off for TB cultures. So blood cultures can be very useful, especially in a disseminated patient. It might actually not have a very bad yield at all. And an early morning urine culture for TB can also be useful, even though the result is going to take a while to get back. With that history of chronic diarrhea, it's absolutely key to send a stool for MCNS, ova, and parasites. We certainly want to do a chest x-ray, even if there's no symptoms, to look, for example, for lymphadenopathy. And you want to try and see if you can get a sputum of some kind on this patient. So while we wait for our results, we do need to manage our patient. And there's a few things that need to happen at this visit already. We have diagnosed oral thrush, so that is something that's easy to manage and can certainly bring the patient some relief. It's a question whether we would deworm at this point. It could be useful with that history of diarrhea as well. I would certainly prefer not to use antibiotics at this point until our stool cultures come back and give us some clue on what the organism might be. We can certainly look at nutritional support, both multivitamins and vitamin B. If the BMI is very low, you can even consider some RUTFs. Paracetamol if the patient is in pain or uncomfortable. And very important to not give INH at this point. So even though we might not have any pulmonary TB symptoms, there's still a risk of extrapulmonary TB, and this patient does not qualify for INH at this point. We need to talk about oral intake, both of fluids and food, small meals with high number of calories. We need to start talking about the ARVs. This patient has never taken ARVs. He's been very sick before he's come in. There might be quite a few issues there in terms of coming to terms with his diagnosis. And we want to see him quite soon. And during your assessment, you need to make a decision also whether it might not be better to admit this patient. So let's look at the results that was obtained at this first bout of investigations. Firstly, from an immunocompromised point of view, yes, CD412, not surprising, very immunocompromised, and that immediately opens up your differential diagnosis dramatically, as there's a whole range of organisms that you will only see in a CD4 under 50. The full blood count there shows that white cell count, hemoglobin, and platelets are all three low. Normocytic, normochromic anemia, but this patient has got a pancytopenia. And that's already a concern. It gives you an idea also that the patient is very ill, but we're starting to worry about disseminated disease and bone marrow infiltration. Liver function test shows that the ALP is raised. That's quite often an indication that something is pressing onto that liver. It could be glands. There could be something infiltrating into that liver. UNE is normal, fortunately. But our blood cultures are not bringing up anything. So although the patient is feverish, we're not finding any signs of bacterial infections or septicemia. CRP 125, not particularly helpful. We know that there's some sort of infection or inflammation going on. And not surprisingly, the patient has no cough. We were unable to get any sputums. So we've not been able to send any gene experts for testing. The stool results came back nil of note. Important, do send 3 samples 3 days in a row. Quite often you might miss the organism, but at the moment they hadn't found anything. And the chest x-ray always got one of those very non-specific diffuse reticulonodular infiltrates, which is not particularly helpful from a diagnostic point of view. So at the moment where we are at is we don't actually have any clear confirmation of TB, or we have any specific diagnosis at all, but we have a very sick patient. But it's been a week since we've done these investigations. The patient has returned and he's lost another 2 kilograms and he's definitely looking worse. So what do we do now? Let's look at some of our options at this point. The temptation is to say, well, let's just try and get a diagnosis, do more investigations, wait until we're sure. We're very suspicious about TB. There's got TB symptoms. ALP is increased, which shows that something might be pushing on the liver. Pancytopenia, very suspicious. There's an increased CRP, which gives us a bit of a clue. But we would like some sort of confirmation, which we don't have yet. Ideally, at this point, we would love, for example, to refer for an ultrasound. We would like to wait for our culture results to come back. The challenge is that we often don't have easy access to ultrasound. And how long can we reasonably wait while we try and confirm the diagnosis? So the other option is to say, well, we will be doing some investigations, but we need to get this guy onto some sort of treatment and to start empiric TB treatment. And in patients with very low CD4 counts, this is often a sensible thing to do, as your investigations might not lead you with very many answers, because the patient has got such a poor immune response to the TB. But also your patient is going to get sicker and is going to potentially die while you're investigating. And the other question is, what do you want to do with the ARVs? Because obviously also from an immunosuppression point of view, this is a major issue. As challenges, you can't possibly start the ARVs if the patient is having some sort of active opportunistic infection going on at the time, as all you're going to do is precipitate a massive iris. So you're getting into a bit of a chicken-egg situation that you actually have to start them on some sort of treatment to see if you can get the opportunistic infection under control before you can even consider ARVs. So let's see what actually happened to this particular patient. And this patient was clinically deteriorating because of the raised CRP, the bone marrow suppression, the palpable liver, possible infiltrate on the chest x-ray, they decided to start on TB treatment. And if the patient improved, remember that CD4 count was very low, then they would start ARVs 2 weeks later. And so they wanted to admit the patient, so they discussed the possibility of admission with the patient, but he was not keen. And so they arranged an outpatient ultrasound, still to help us find a diagnosis. They sent some TB-specific blood cultures and hopefully also urine culture could have been done at this point. And they have put in the notes that if none of this comes up with any particular confirmation of what's going on, we could also consider a bone marrow aspirate. So an abdominal ultrasound did happen within a few days and very usefully showed a diffuse infiltrate in the liver and some splenic microabscesses. Kidneys and gallbladder was otherwise normal. And these are both very suspicious of extrapulmonary TB. So great, we see this ultrasound result, and that's very reassuring to think, great, it looks like we are probably dealing with TB. The patient's seen 2 weeks later, but the diarrhea settled a bit, the night sweats have stopped, and it feels like maybe we're on the right track. We haven't got our TB blood culture results back, and we decide not to do a bone marrow aspirate at the moment. If you've got a patient with HIV and a pancytopenia, by far the most common cause is tuberculosis, and it's quite appropriate to first treat the TB and see if the pancytopenia recovers itself. It's not necessarily to do a bone marrow aspirate early on in the disease. And after 2 weeks of TB treatment, there is definitely some improvement, and so it was decided to also start the patient on ARVs at this point. So now it's 2 weeks later. So remember, our patient was started on TB treatment about a month ago and was started on ARVs 2 weeks ago. Comes back and he's looking much worse. The diarrhea has recurred, and now when you examine the patient, he's dehydrated, he's unable to stand, he's pale, very tachycardic, very low blood pressure and pyrexial. And this time he agrees to admission. The patient is put in the ward. At the moment we are continuing with our ARVs and our TB treatment, and we start repeating all the relevant bloods. So what are we thinking about at this point? And of course, we're still very much worried about this TB. He was started on ARVs 2 weeks ago, and we're now concerned, are we having a massive TB iris? So this will be what we would call a paradoxical TB iris, if this is what it was. Patients seem to be getting better on TB treatment. We put them on ARVs, and now they're getting a lot worse. And this is due to an increased inflammation against the TB caused by this immune system that is reconstituting. But also maybe the TB is not responding properly to treatment. Maybe it's an MDR, for example, and we are having a massive iris because of that. But maybe it's not TB at all, and this is very important, why that initial differential diagnosis is so important. Maybe it's a non-tuberculosis bacterium like MAC. Maybe it's some other disseminated infection, for example, such as histoplasmosis. It could even be something like a disseminated Kaposi of the gut. And maybe the gastroenteritis is something else going on which we just missed on the stool. Maybe there's a Salmonella or a Shigella, or there is still an ongoing Cryptosporidium that we just didn't find on the culture in the first place. And there's various other things we will be considering at this point, but these are some of our main concerns. So let's see what is our first blood results that come back after admission. And it's showing that the kidneys are now also taking strain. Our patient's hyperkalemic, hyponatremic, urea and creatinine are both raised. Our LFTs have gotten worse. So both the ALP and gamma GT is raised even further. So this obstructive picture is worsening. But there's now also an hepatocellular component with the ALT and AST at about the 3 times the upper limit of normal. Pancytopenia is worsening, and all the blood cultures have not yet shown us anything. So this is a great slide that summarizes an approach to what you do with somebody who's on TB treatment and who's getting worse. And a very important slide. You should print this and put this up on your walls, because a common reason for diagnosis is admitting people who are very sick, quite often diagnosed with TB, and then while you're treating them, they suddenly start getting worse. And these are the patients who often die before we actually have managed to even figure out why they're not responding to their TB treatment. So there are 7 different things I want you to think about when you have a patient who's on TB treatment and they're not responding. And the first one there is just double check if they're actually taking their treatment. They might not have been picking up drugs, they might be struggling to swallow, and it's good to get collateral information from family at this point. Always check about drug side effects, because that's the most common reasons why patients might not be taking their treatment properly, or there might be drug interactions with other drugs. And then, of course, we do want to have in our mind at this point the possibility that this might be MDR-TB and the treatment is not responding to treatment. Luckily, we are doing gene experts at the beginning, so if you still haven't got some sort of gene expert sample, try and get one, whether it be out of a lymph node, a pleural effusion, on LP, see if we can get some sort of clue to be able to at least check for rifampicin resistance. Very important is to not just go down the MDR or the TB route, it's just maybe you've got the wrong diagnosis. Although TB is common, not everything that looks like TB is TB. And there's lots of other possible infections, for example, that can be affecting your pulmonary or pleural system, from your normal straightforward pneumonias to PJP or Kaposi's. There might be an embolism. There might be some of your rarer fungal things like histoplasmosis. There might be some of your viral infections, such as chickenpox or measles. You also need to think in terms of, it might be the disseminated picture you look at might be primarily to do with your central nervous system. And patients with low CD4 counts might not make your typical inflammation, so they might not present with classic neurological symptoms. So an LP would be very useful at this point. And also the patient there might be other things presenting, causing the wasting syndrome, generalized illnesses such as your MAC, some of the other systemic fungal infections, etc. TB iris is actually slightly lower down the list. It is common, but not usually make patients that sick. And with TB iris, we're talking about a patient who has improved on their TB symptoms, and now when we start them on ARVs, they're suddenly getting worse. We call this paradoxical iris because the patient was initially better, and now they're getting sicker. The important thing with these patients is we actually want to continue keeping the treatment going, because the TB treatment is actually the correct treatment. Their own body is just overreacting to the organism. But strangely enough, you can get patients who have a paradoxical reaction. So you can have almost a TB iris for patients who are not on ARVs. So these are patients who do have TB symptoms. They are on the right treatment. But as their TB gets treated, their own immune system also reconstitutes a little bit, and you can have a slight paradoxical reaction for a short period of time. And lastly, just to be aware of malabsorption. If the patient has a lot of diarrhea, for example, they might not be absorbing all the treatment, and making sure they're on the correct TB dose for weight. So this is a nice systematic flow diagram or algorithm you can go through when your patient is not doing well on treatment. So let's see what actually happened in real life with Mr. PK. This stage, they decided to do a bone marrow to see if they could better clarify their diagnosis. There was Zeal-Nelson positive, so there was AFBs on that bone marrow aspirate. There was a granulomatous infiltrate, and it was sent for TB culture. Previous TB blood cultures also got reported AFBs on it, but we were still waiting for the confirmation of the organism. And the patient in hospital is still continuing to deteriorate. So it's day 3 now, and he's starting to look terminally ill with reduced level of consciousness. So what do we do now? The patient has got proven AFB positive. It's clearly disseminated disease. The TB treatment is obviously not working. The ART is obviously making things worse, so the patient might be irising. And we are having to say at this point, if we are still waiting for results to come back, should we not perhaps start some sort of empiric treatment to help this patient along? So if you've got now positive AFBs, it means we're definitely within the realm of a Mycobacterium. But this is the point where you might start looking at alternate diagnosis. It might be MDR, but also it might be Mycobacterium Avium complex. And this is something that we want you to start thinking about in your patient where you've got positive AFBs, you've got a very typical TB picture, but your patient's not responding to TB treatment. And we see MACs in very low CD4 counts. And they've got the typical constitutional symptoms of TB, so fever, night sweats, weight loss, but there's other features that can make you suspicious. So they may have chronic diarrhea, quite a lot of abdominal symptoms. More typically, they'll have more abdominal symptoms than TB normally does. And this total marrow suppression or the pancytopenia is a very typical feature of MAC. You may see the raised ALPs quite often out of proportion with the LFTs because there's infiltration into the liver, significant lymphadenopathy. And quite interestingly, MAC often do not have so much of a chest involvement. It's much more of an extrapulmonary TB picture than a pulmonary TB picture. So how are we going to diagnose our MAC now? And the first thing is you might need to have a high index of suspicion. These are your patients with your very low CD4 counts. They'll have TB symptoms, but they're not responding to your TB treatment. And you may have to decide that while I'm waiting for my culture results, I'm actually going to have to give this patient empiric MAC treatment. Your cultures might take pretty quick if you're lucky, if there is enough bacilli. You can send blood cultures, bone marrow cultures can be very useful. And interestingly enough, the yield would increase in the patients with low CD4 counts. If there's a lymph node, you can send a fine needle aspirate or do a biopsy. And liver biopsies are not really very accessible for most of us in hospital setting, but could also be useful. Both sputum and stool are quite unreliable because we do see that people are frequently colonized by MAC. So MAC is a ubiquitous organisms found within our normal environment, and lots of patients have them. It's only in the very low CD4 counts that they cause trouble. Sometimes difficult to know whether what you're finding is significant. To be able to diagnose non-tuberculosis mycobacterial disease, it is recommended that you have to have positive culture results from at least 2 separate sputum samples or other kind of samples. Let's continue the story of PK, and unfortunately he passed away 5 days after being admitted to hospitals. And when the bone marrow culture later came back, it did confirm that it was a Mycobacterium avium complex. Art obviously may have worsened the condition due to the iris of the incompletely treated MAC, but still without ARVs, the HIV could also have overwhelmed him. So what treatment would we have needed to use for this gentleman? And the preferred antibiotic regimen for MAC is usually 2 drugs at least, which is your clarithromycin as well as ethambutol. And quite often, if possible, a 3rd drug, rifabutin, is used to reduce the possible resistance. We often don't have clarithromycin, and one can use azithromycin. Azithromycin might be a better choice because it has much less drug interactions. And just to remember that MAC is not sensitive to rifampicin, isoniazid, or PZA, so your TB treatment on its own is not going to work. But it's sometimes very difficult to know whether the MAC is a complication of the patient already having TB. And so quite often what sometimes happens, if you've had a patient on TB treatment and you're thinking it might also be MAC, is you might just add in extra drugs to cover both. And just a reminder that both clarithromycin and rifabutin has interactions with various ARVs, and you might have to check with the Medicine Information Center or your formulary to ensure your patient's on the correct ARV regimen. Just a quick slide on MAC iris. So irises with MAC is quite common. It can usually occur about 1 to 3 weeks after ART initiation, and it's typically in patients where the CD4 count is going up rapidly or a rapid virological suppression. So of course most of our MAC patients have got very low CD4 counts, and if they respond very well to the ARVs, they're actually at a higher risk of that iris. And it can present in all kinds of ways. It can present like an adenitis. You can actually get skin or deep tissue abscesses due to MAC, and you can even get hepatic granulomas with very deranged LFTs. MAC iris is similar to TB iris. The focus is to keep them on the MAC treatment and to keep them on those ARVs, lots of reassurance. Systemic steroids can always be an option if you are concerned that the iris is actually going to overwhelm the patient, that the inflammation is so much. If you're starting to consider steroids, you need to be consulting an expert about these patients. And in symptomatic management, very important. Look after that diarrhea, use NSAIDs for your pain. very important to keep your nutritional support on board. Both the HIV and the TB will be using a lot more energy resources, and we need to make sure we're keeping on top of it. And if there are abscesses, to aspirate and manage those. We generally don't discontinue ART in high-risk conditions because it's also absolutely essential to start managing the HIV unless you feel that the iris is actually life-threatening. When would you stop your MAC treatment? There's actually very specific criteria for this. The patient must have had a CD4 for more than 100 for a minimum of 6 months. And the MAC treatment must have been for at least a year, and the patient must be completely well and asymptomatic now. If the CD4 in the future does drop under 100, you may restart the MAC treatment, even if it's just the 2 basic drugs to use as prevention for possible relapse. Thank you very much. I hope that's given you a bit of a direction in terms of assessing your very ill patient with complicated disease. There is also a handout that you can download from the link below in the notes section. Thank you.